Recognizing and Managing Disorders of Precocious Puberty. Mike T. Swinyard, MD, Fab. Board Certified Pediatric Endocrinology/Diabetes. Mountain Vista Medicine, PC. South Jordan, Utah. MikeMountainVistaMedicine.com. 801-838-9090. At the conclusion of this presentation, participants will be able to explain puberty to families, so they can understand the basis for any necessary laboratory testing to evaluate abnormal early puberty. Compare and contrast premature adrenarche with normal puberty. Compare and contrast premature LRHA with normal puberty. I have worked in both a general pediatric setting and a pediatric endocrine setting. I would like to present information that I wish I knew before. Growth and puberty assessment. Detailed medical history. Detailed physical exam. Bone age assessment, the single most important test to order. Focused and precise laboratory testing. An appropriate growth assessment will include, let's discuss each one in detail. Medical history, onset and progression of signs of puberty. Patient's stage of puberty, as estimated by family. Mother's height and age of menarche. Father's height and age of pubertal growth spurt. Family's concerns, assess their anxiety and agenda, as preparation for your opportunity to teach them. Current and previous illnesses/trauma/surgery. Exposure to cosmetics/topical hormones. Add more to chronic disease, add more to meds. Physical exam. An accurate determination of height is crucial, using a reliable stadiometer at those aged 2 years and over. For those patients under 2 years old, care should be taken to measure an accurate length, and phantometer more reliable than making 2 marks on exam table paper. Technique is important. Using centimeters has less potential for error in rounding, etc. Physical exam accurately recording height is crucial. Plot both parents' heights on growth chart. Determine if project and adult height is consistent with parental height. How to determine mid-parental target height needed. Physical exam. In assessing growth, the pattern of growth over time is more useful than a single measurement of height. Determine interval growth and annual growth velocity from previous height measurements. Plot growth velocity on growth velocity chart. Calculating growth velocity. Example. October 2, 2007 height, 112.0 centimeters. April 12, 2008 height, 114.4 centimeters. Interval growth in 6 months. 114.2 to 112.0 equals 2.4. Annual growth rate determined by projecting interval growth for 12 months. AX12/B equals growth velocity. A equals interval growth, B equals months between measurements. 2.4x12/6 equals 4.8 centimeters/year. Growth velocity chart with info on how to determine growth velocity. Physical exam. Females, staging breast development, contour, nod size. Males, staging of testicular size, length. Skin exam, café au lait spots. Enlarged, rubbery thyroid suggestive of Hashimoto's thyroiditis. Tanner stages for girls, breast development. Tanner stage 1 no breast tissue. Beware of liphomastia as an imitator. Donut sign. Tanner stage 2 areolar enlargement with breast bud. Tanner stage 3 enlargement of breast and areola as single mount. Tanner stage 4 projection of areola above breast as double mount. Tanner stage 5 adult, papilla, nipple, projects out of areola. Stage 4 and stage 5 of may be difficult to distinguish. Tanner stages for boys, testicular length. Tanner stage 1 prepubertal. Length is less than 2.5 centimeters, less than 1 inch. Gently stretch scrotum over testis. Tanner stage 2 testicular length is 2.5 cm, 1 inch. Tanner stage 3 testicular length is 3 cm. Tanner stage 4 testicular length is 3.5 cm. Tanner stage 5 testicular length is 4 cm or greater. Tanner stages for pubic hair. Tanner stage 1 vellus hair similar to abdominal wall or no hair at all. Tanner stage 2 dark, sparse hair at base of penis or along inner labia majora. Tanner stage 3 dark, curled hair spreading over junction of pubes. Tanner stage 4 adult type of hair, but no spread to medial thigh. Tanner stage 5 spread to medial thigh and growth or escutcheon. Average timing of pubertal events in girls. Onset of breast development age 10. Tanner stage 2 to menarche 2 years. Growth rate tapers after menarche. Age in menarche 12 years. Start to finish, end of growth, 3 years. Explain how bone age and IGFI help in determining cause of short stature, average timing of pubertal events in boys. Onset of testicular enlargement 11.5 years. Time from onset of puberty to Tanner 2 years. Stage 4, beginning of growth spurt. Start to finish, end of growth, 4 years. Remember in both girls and boys. The peak growth rate occurs in the second half of puberty, Tanner stage 3 and later. Definition of precocious puberty. Secondary sexual characteristics 7 before age 8 years in girls. Secondary sexual characteristics 7 before age 9 years in boys. Classification of precocious puberty. Gonadotropin dependent, central or true precocious puberty. Characteristics match gender of patient, isosexual. Gonadotropin independent, peripheral precocious puberty. Characteristics may be isosexual or contrasexual, inappropriate for child's gender, including virilization, masculinization of girls or feminization of boys. Incomplete precocious puberty, normal variants, including premature LRSA and premature drenarche. Gonadotropin-dependent precocious puberty. Early maturation of the hypothalamic pituitary gonadal axis. Idiopathic in more than 80%. Almost all idiopathic cases are in girls. Causes of gonadotropin-independent precocious puberty. Excess, independent or unregulated, secretion of sex hormones, androgens or estrogens, from the gonads or adrenals. Exposure to exogenous sources of sex steroids, estrogen-containing creams, testosterone jelly used to treat adult hypogonadism in men. Ectopic production of HCG from a germ cell tumor. Very rare disorders, McQueen-Albright syndrome. May be helpful to mark chart and closely monitor growth of child during WCC. Premature LRSA. Isolated and non-progressive breast development in an infant/toddler girl. No acceleration of height growth. No acceleration of bone development. Less than 2 SDs above the mean for chronological age. Premature drenarche. Early appearance of adrenal androgen-mediated skin changes in any combination of pubic hair, axillary hair, body odor, oily skin, oily hair, and mild acne, in either boys or girls. No clitoromegaly in girls, no larger than a pencil eraser or less than 5 mm in diameter. No acceleration in height growth or advanced bone development, less than 2 SDs above the mean for chronological age. Bone age assessment. Determined by a radiograph of the left hand and wrist compared with the standards in the Groylic and Pilot list for males and females. The delay, or advancement, of the bone age is expressed in standard deviations, SDs, below or above the patient's chronological age. An advanced bone age is 2 or more SDs above the mean for chronological age. Obese children or children with tall stature and tall parents may have a bone age which is 2 to 3 SDs above the mean for chronological age. Evaluation of precocious puberty in the primary care setting. The most helpful screening test in the workup of the patient with precocious puberty is the bone age. It is non-invasive and provides valuable information as to whether further testing may even be needed. Few other tests used in medicine can make that claim. Decreased growth rate, Isaac Ibsen. LH and FSH testing proceed with caution. Although readily available at hospital and reference laboratories, measurement of LH and FSH in children is fraught with problems, including need for relatively higher sample volumes in children, very poor sensitivity at the levels seen in the earliest stages of puberty. LH and FSH testing. If incomplete forms of early puberty, premature LRSA or premature adrenarche, are not a possibility, then measure LH, FSH and estradiol, in girls, and LH, FSH and total testosterone, in boys, with isosexual precocious puberty. Send out these labs to Esoterics or Quest Diagnostics for high-sensitive assays to save your patients a redraw. Review. Measurement of LH and FSH will guide the evaluation of precocious puberty, if development is isosexual. Also measure total testosterone in boys and estradiol in girls. Measurement of LH and FSH will not help the evaluation of contrasexual development, since it is contrary to the patient's gender and not consistent with activation of the hypothalamic pituitary gonadal axis. Review. Central precocious puberty is gonadotropin dependent, so LH and FSH levels are detectable. Peripheral precocious puberty is gonadotropin independent, so LH and FSH levels are very low or undetectable. Additional studies. Isosexual central precocious puberty in girls with pubic hair and breast growth, or any girl with menstrual periods. Pelvic ultrasound to assess uterus/ovaries. Pituitary MRI and oral peroxide stimulation testing after consultation with a pediatric endocrinologist. Additional studies. Isosexual central precocious puberty, penile and testicular enlargement, in boys. Pituitary MRI and oral peroxide stimulation testing after consultation with a pediatric endocrinologist. SS greater than 3 ST not growing according to FH background, find a chart. Additional studies. Contrasexual peripheral precocious puberty in viralized girls, clitoromegaly, with or without pubic hair. Total testosterone is an overall indicator of androgen exposure. DHEA sulfate is a screen for virilizing adrenal tumor. 17-hydroxyprogesterone and androstenedione is a screen for congenital adrenal hyperplasia. Active stimulation testing or adrenal imaging next with guidance from pediatric endocrinologist. Additional studies. Isosexual peripheral precocious puberty in boys with or without pubic hair. HCG measurement for testicular tumor. DHEA sulfate is a screen for virilizing adrenal tumor. 17-hydroxyprogesterone and androstenedione is a screen for congenital adrenal hyperplasia. Active stimulation testing, adrenal, or testicular imaging next with guidance from pediatric endocrinologist. Treatment. Incomplete precocious puberty, premature LRSA and premature adrenarche. Reassurance and follow-up. Central precocious puberty, treatment is GnRH agonists, for example Lupron. Peripheral precocious puberty, eliminate exposure to exogenous source of sex steroids, surgery to remove testicular, ovarian or adrenal tumor or ovarian follicular cyst. Sometimes growth is straightforward, other times it is inconclusive. Treatment. 2. Peripheral precocious puberty, rare forms. Congenital adrenal hyperplasia is treated with glucocorticoids. McQueen-Albright syndrome and familial male-limited precocious puberty are treated with aromatase inhibitors and antiandrogens. References. Carl J.C., Lesch A.J. Clinical Practice, Precocious Puberty. In Engel J. Med 2008, 358-2366. Miri Precocious Puberty. Pediatra Rev 2006, 27-373. Case Study Number 1. 8-year-old boy with several dark pubic hairs at the base of the penis for the past several months. No genital enlargement. He has always been tall, as per parents. They describe him as moody and quick to cry. They have noticed strong body odor and oily hair. PMH unremarkable. Father 6'2". Mother 5'10". Height and weight are at the 97th percentile. Tan or stage 3 pubic hair with testicle less than 2.5 cm. Case study number 1. Bone age is 9.5 years, which is 18 months, 2 STs, above the mean for chronological age. Diagnosis. Treatment. Case study number 2. 7.5-year-old African American girl who experienced a menstrual period a few months before. She has pubic hair, body odor, oily skin and mild acne. Mother is 5'6" with menarche at age 12. Father's height and onset of puberty are not available. Child is at the 90th percentile for both height and weight with no recent acceleration in either parameter. Child is tan or stage 4 for both pubic hair and breast development. No cafeoli spots. FTT. Case study number 2. Bone age is 11 years at a chronological age of 7 7/12 years. This is 3.4 STs above the mean for chronological age. LH was 18, and alpha for pubertal girls is less than 0.03. FSH was 8.5, and L is less than 4.2, and estradiol was 39, and L less than 15. These results were during leuprolide stimulation testing. Case study number 2. Pelvic ultrasound was read as abnormal because of a prominent endometrial stripe on the lateral views, which is typically seen in pubertal girls. Ovaries were unremarkable. Pituitary MRI indicated some slight prominence of the gland, given her age, but no overt pathology. Case study number 2. Treatment with Lupron has stabilized bone development and she has had no further menstrual periods. She continues to be at tan or stage 4 for pubertal development. Case study number 3. A 6-year-old girl developed a bump in the left breast over the preceding several months. This had progressed to both sides, but most recently the right side regressed, so only left-sided breast growth remains. She has had no vaginal discharge, neither bloody or mucus in nature. No pubic hair growth, body odor or skin changes. No acceleration in height growth. Case study number 3. Mother is 5'7" with onset of menarche at age 12 years. Father is 5'11" with normal onset of puberty. Height and weight are at the 50th percentile. Tan or stage 2 on the left. Tan or 1 on right. Tan or stage 1 pubic hair. Case study number 3. Bone age is 1 ST above the mean. What next? Case study number 3. LH was 0.021, and L is less than 0.03. FSH was 0.664, and L is less than 4.2. Estradiol was 2.0, and L is less than 15. Diagnosis? What next?